My name's Savannah and this is Alondra, and we're going to be talking about exposure and response prevention with OCD. Alondra is going to be covering the overview, theories and models, and then techniques and principles.
So let's start with a brief overview of exposure and response prevention therapy. So from the readings, we discovered that there are 5 features of all exposure-based treatments. So number 1 is the development of anxiety hierarchies. Number 2 is the imaginal or in vivo systematic desensitization, which can be completed through modeling. Number 3 is cognitive restructuring. Number 4 is encouragement of expressions, and number 5 is paying attention to any family-related issues that may be having an effect on the phobia. So exposure and response prevention therapy, it has 2 components to it. So the exposure part is exposing the client to thoughts, images, objects, and situations that cause anxiety. And response prevention is not having the client engage in the compulsion once the trigger is present. So theories and models associated with exposure and response prevention therapy. So the first person that was able to use ERP was Victor Mayer, and he used it with OCD patients. The research shows that he had a really good outcome with the patients that he used it on. He also noticed that there is a psychological model associated with ERP, and it includes principles of learning and emotion. It also includes a behavioral mechanism which allows the client to have an opportunity for extinction of the feared stimuli. It has a cognitive mechanism which helps the client correct dysfunctional beliefs. It has changes in self-efficacy, which allows the client to increase a sense of mastering. Also, ERP falls within the empowerment theory, which allows the client to have an increase in self-determination and autonomy. All right, so now we're going to be moving on to techniques associated with exposure and response prevention therapy. So number 1 is flooding, and flooding is just prolonged and intensive exposure, which usually lasts anywhere from 30 minutes to 8 hours to the feared object until the anxiety is reduced. The other one is graduated exposure. The third one is systematic desensitization, which is it begins by setting up an anxiety hierarchy of the fears that the person has and organizing them according to severity. And the therapist will begin by showing the least frightening presentation of the feared object. And then we'll use relaxation techniques to help the person become comfortable, and moves to a presentation of the feared object, gradually moving up the hierarchy. So the next one is virtual reality, and then there's pacing of exposure, which includes intensive therapy that occurs in one extended 2 to 3 hour session. Treatments are spaced out over weeks, and graduated treatment that slowly moves up the hierarchy of anxiety. And then we have cognitive restructuring. So for exposure and response prevention therapy, it uses graduated exposure, which exposes the clients to situations of low anxiety and then slowly moves to higher levels of anxiety provoking stimuli. Sessions usually run anywhere from 45 minutes to 2 hours. This is done in order for the client to be able to experience low anxiety and then higher levels of anxiety. So in ERP, the first step should involve a clear understanding of the frequency, nature, and severity of the obsession and compulsion. So now Savannah is going to talk about the population setting the target population of the risk and protective factors associated with ERP, and the literature that we found while researching.
In regards to the population and setting, ERP is designed for individuals with a diagnosis of OCD. OCD affects 1 in 40 adults in the U.S. and 1 in 100 children in the U.S. Most individuals are diagnosed with OCD by age 19. OCD affects males and females equally. 1/3 of adults develop symptoms of OCD in childhood. ERP can be conducted in any setting and was designed to be conducted in the environment in which the individual with OCD could encounter an object of their obsession. For example, if somebody has an obsession with germs, maybe the ERP would be conducted in a public restroom. However, ERP can also be conducted in a neutral space, such as an office or a person's home. And the exposure and response prevention can be done using visualization techniques to imagine the confrontation with the feared object. When talking about the target population, there are some protective factors. Individuals that stay in treatment for OCD tend to have high rates of treatment success. Small amounts of time between the onset of OCD and treatment seeking is also a protective factor. Positive family involvement in the ERP treatment can improve outcomes for teens and children. Insight into the irrationality of thoughts and actions is also considered a protective factor. In terms of risk factors, individuals with OCD have a tendency to drop out of treatment. Family dysfunction and hostility tend to be negative predictors of treatment success. Co-occurring hoarding behaviors or schizotypal personality disorders are considered risk factors. Individuals diagnosed with OCD have a higher suicide attempt rate than those in the general population. This is really important to keep in mind when working with patients who have OCD diagnoses. In the literature about OCD and exposure response prevention, we found several articles. Research and control trials provide evidence that ERP is more effective than a placebo, relaxation techniques, and control therapies. An example of a control therapy would be anxiety management training. In a randomized 3-week trial of ERP or anxiety management, ERP participants had a 62% reduction in symptoms. This is compared to the anxiety management group, which had a 6% increase. In multiple studies of randomized trials with cognitive therapies, or ERP, those in the ERP group had a great improvement at follow-up. Follow-up being 1 week, 1 year, and 3 years. According to Seligman, 83% of individuals in 12 different outcome studies had a positive response to ERP. ERP has additionally been found to be effective with individuals who have mental rituals and or obsessional symptoms. It's important to remember that remission of phobias are highly unlikely. Treatments for OCD are intended to decrease symptoms and make everyday life more manageable for those individuals who have OCD. Statistics show that those who partake in ERP tend to have longer lasting treatment effects, which is why it's always recommended as a first intervention for those who are willing to participate.
So there's currently no information available on the effectiveness of medication alone in treating OCD. However, when phobias are comorbid with other disorders such as severe depression and panic attacks, medication may be useful in conjunction with them, in conjunction with exposure and response prevention therapy.
Thank you for listening to our presentation. In our next video, you will see Emily and Megan as they perform a small session of exposure and response prevention.